like sleep medicine has not done a very good job at like spreading the word, right? Like in residency in med school, we get like 4 hours of education on sleep. We get just a few hours of education on nutrition. We get a few hours of education on exercise. So like a lot of these basic foundational things, we don't get a lot of education on. And if someone is a good sleeper and they don't have any suspected sleep issues, and well, using a medical grade device is probably more friction than it is comfort. And I think as a result of that, we don't know how to ask patients the appropriate questions to figure out what's the problem.
The views, opinions, and statements expressed by our guests are solely their own and do not necessarily reflect those of Dr. Jason Littleton or the Concierge Doc Podcast. We do not endorse or take responsibility for any statements, claims, or perspectives shared in this content. Viewers are encouraged to conduct their own research and form their own conclusions.
Access to the information and materials contained in this podcast is at your own risk. The information contained is presented for the purpose of educating the consumer on a variety of wellness and healthcare topics. The information. Nothing contained is intended to be instructional for medical diagnosis or treatment. The information contained is compiled from a variety of sources. The information should not be considered complete and exhaustive and should not be in place of a visit or consultation with your own primary care doctor. Welcome to the Concierge Doc Podcast. I'm your host, CEO and founder of Littleton Concierge Medicine, Dr. Jason Littleton. Welcome to the podcast. Today, we got a good friend of mine. I'm really excited. He's a Harvard-trained sleep physician and one of the leading voices at the intersection of sleep, longevity, and human performance. With expertise in critical care, pulmonary, and sleep medicine, he has witnessed firsthand how fragmented approaches to health limit both lifespan and health span. Today, he is reimagining sleep not as a nightly necessity, but as the single most powerful lever we have to extend vitality and unlock human potential. He's the co-founder and chief medical officer of Empower Sleep and has served thousands of patients globally. He's pioneering a new era of continuous longitudinal sleep testing using medical-grade wearables and AI, and he's going to talk about that today in our podcast. His team has built one of the largest sleep data sets of its kind, enabling high personalized interventions that are reshaping outcomes for patients, high performance leaders, and athletes. This approach challenges the outdated model of single night sleep studies and instead frames sleep as a dynamic biomarker of aging, resilience, and recovery. Welcome to the Concierge Doc Podcast, Dr. Sahil Chopra.
Thank you, Dr. Littleton. It's a pleasure. It's a pleasure to chat with you today.
Listen, I love that you're here. I want to talk about sleep, and I want to talk about your background and why you got into this and what made a difference, because I know that you're intensivist, trained, and you used to work in the ICUs, and now you're doing and helping people with sleep medicine. Tell us a little bit about that.
Yeah, I still do about maybe 10% of my time in the ICU. I'll cover weekends and sometimes like a Friday, Saturday, Sunday, just to maintain ICU, level of skills. But I really, otherwise, I feel like 100% of my time I'm doing something related to sleep. And it's been a lot of fun. It's very fulfilling. In the ICU, we take care of people who are at the end of their life sometimes, or most of the time. But when we talk about sleep, we get to play a role much earlier on before someone ends up in a critically ill condition. So I really enjoy the ability to have conversations with people and look at health from a more preventative lens.
I think that what you do is tremendously changing lives, because I think the number one thing that I hear in practice is that people can't sleep, whether it's because of racing thoughts, whether it's because of sleep apnea, or they just can't stay asleep. I mean, multitude of things that are at work when it comes to helping people to get a great night's sleep. And I know you run across these type of complaints as well and these type of concerns. How are you changing the game? Tell us a little bit about that, about how are you helping people to get sleep? Can what you do help anyone get better sleep?
Yeah, the short answer is yes. And, traditional medicine, it's kind of like sleep medicine has not done a very good job at like spreading the word, right? Like in residency, in med school, we get like 4 hours of education on sleep. We get just a few hours of education on nutrition. We get a few hours of education on exercise. So like a lot of these basic foundational things, we don't get a lot of education on. And I think as a result of that, we don't know how to ask patients the appropriate questions to figure out what's the problem. We do a really good job. Like if someone comes in with chest pain or cough, like we know exactly what to do, like what tests to order. And unfortunately, like when someone comes in with like a sleep complaint, like, hey, doc, I don't sleep well, I don't feel rested, I wake up a lot in the middle of the night. Many times we don't order the appropriate investigations. And it's very common for someone who has any kind of a symptom to automatically get some kind of a intervention, medication, supplement, new mattress, blackout curtains, eye mask. I mean, it's a very long list. But if someone came to you for knee pain or chest pain, you would order blood test, echo, x-ray, something along those lines. And in sleep medicine, like that doesn't really happen. Someone says, I don't sleep well. They get prescribed something without trying to understand like what's the root cause of that problem. And one of the things that I've been like really pushing is helping people order the appropriate investigation when someone has a complaint around their sleep. And in sleep medicine, that investigation is a sleep study, a sleep test. And it can either happen at home, it can happen in a lab. And the way that, even the former version of myself, I used to think of a sleep test as a sleep apnea test, when in fact it's like much more beyond that. Like when you order a chest x-ray for someone who has a cough, it's not a pneumonia test, it's an x-ray.
Right.
You can see so many things. You can see heart size, effusions, pneumonias, broken ribs. There's so much that one can see on a chest x-ray. And similarly, a sleep study, a sleep test, is an assessment of what is the physiology of your sleep. How healthy is your sleep? And when we look at sleep testing that way, we can start to see things that we would have been sort of blinded to otherwise. But it sort of goes back to like someone has a complaint of something related to their sleep, and the basic thing to do is to do a sleep assessment, which is a mix of a history, a mix of a sleep study, and then sort of use that information to then provide like personalized guidance of like, this is why you're not sleeping well, rather than assuming, being more precise and accurate of like, this is why I think you're not sleeping well, and this is going to be the appropriate way to solve that problem.
Yeah, I love that. Now, you said something that really stood out to me there. I said a lot of things that stood out, but one of the things is people aren't asking the right questions. What are the right questions?
It's like the screener that I like to use, and this is not validated. This is my personal opinion. There's a variety of different questionnaires that one can use depending on the complaint that the patient has. So there are screeners. Like the first sort of 4 questions that I ask everybody is, and it gives a clue into is there a sleep problem or not, is do you have a hard time falling asleep? Do you have a hard time staying asleep? Do you wake up unrested? And do you feel tired during the day? If anybody screens positive for any of those like symptoms, or any of those questions, that person needs a little bit more investigation. Mm-hmm. And what that means is like we need to then ask the appropriate questions to look for sleep apnea. We need to ask the appropriate questions to look for insomnia. We need to ask the appropriate questions to look for restless leg syndrome or someone's chronotype. Are they early to bed, early to rise, late to bed, late to rise? So we can ask these very specific questions about looking for a possible sleep disorder. And then other questions, obviously, are medications, mental health, and there's a variety of things that one can, like a checklist that one can go down, trying to tease out what could be the driver of a sleep issue.
I feel like when I'm working with patients who have difficulty sleeping, it's very easy to go to a prescription medicine when you have to tweet out what's behind their insomnia when it comes to even mental health questions like anxiety, depression, dealing with racing thoughts. And I think there is a pressure in the medical world to just prescribe a quick medicine and not deal with the organic causes, the thoughts people are having, just the mental health aspect. And I think what is happening is we're just putting a Band-Aid over that. And that's a concern of mine. Would you not agree?
Yeah, no, 100%. That's why I love your practice, right? I mean, that's why I love like what you guys are doing, where you have the time to have a conversation, you have the time to sort of like try to tease apart what's like the chicken or the egg here. Is it anxiety that resulted in a sleep issue, or is it a sleep issue that resulted in the anxiety? And but you're totally spot on. Like it's our responsibility to try to figure this out. And if we do need to prescribe because there is an acute problem and the person needs to sleep, we prescribe with some kind of an exit strategy. Okay, like I know like there's a crisis right now. Someone died, there's a health issue, there's something going on, and I know that you need to sleep. But in addition to this like 3-week, 4-week prescription that I will give you, these are the behaviors that we need to incorporate. These are the strategies that we need to incorporate while we do this, so that this does not turn into a chronic problem.
Yeah.
And I think like there's a ton of opportunity to be able to help people that way.
Yeah, I like what you said, exit strategy. This sleep in itself obviously is a whole discipline and department category, because really tweeting that out, having an exit strategy, having people understand what sleep hygiene is, and then playing that out is really key. Yeah, I like that. When you are referred a patient and you're meeting them for the first time and you're doing your evaluation and you use some of your new technologies, the wearables, the AI, walk us through what it's like for that new patient to first meet you and then go through the evaluation and then get to the testing and the wearables and your use of AI technology. Walk us through that.
Yeah, it starts off with a very detailed history, kind of like what you're doing in your practice, where you want to spend time to understand their overall medical health, mental health, their daytime routines, their evening routines, the time period over which they've developed a sleep issue. Was there a precipitating event? What are some of the symptoms? What are some of the things that they screen positive for? And depending on what I think could be driving it, I will have some preliminary diagnosis in my head already, even while I order the sleep study for them. Right? Like when someone comes to you with shortness of breath, when you get a history, you're either thinking of heart failure, COPD, pneumonia, something along. You examine them and you have like something in your mind already of this is what I think is going on. I'm going to confirm it with some kind of imaging. Similarly, like we're doing the same thing when we have our patients go through sleep testing. And luckily, the testing that we use for patients is mostly home-based testing, and it's multi-night testing, where after we've gathered a lot of history, we'll mail patients a ring-based device. It's a medical-grade home sleep testing system, and we'll have them get about 7 to 10 nights of baseline data to give me some context on what is their sleep health like with the routines that they have just described to me. exercise, alcohol, supplements, meditation, whatever it is that is a part of their daily routine. I want to understand what is their sleep with those routines. Some of those habits we'll figure out over time are conducive to sleep. Some of those habits we'll learn over time are not conducive to sleep. And then accordingly, we can, one, identify what's the root cause, but then we can also identify what are the things that can be added and peeled off that over time will result in this person having substantially better sleep.
Yeah.
It's kind of like the CGM idea, right? Like if someone comes to you with a hemoglobin A1C of, 7, like giving them a CGM trial for a couple of weeks is like really formative and very powerful before even doing anything, because then it allows you as the doctor to give them guidance on like what to do from a nutritional standpoint, what to do from an exercise standpoint, what to do from a supplement medication management standpoint, and you can build a very personalized stack of systems for them. And we're doing the same thing with sleep. And because we have so much data over time, we get the help of like AI to help us sort of parse through the data in a more efficient way to help us see things that we wouldn't see otherwise and be able to provide the recommendations that would otherwise take a really long time to sort of put together.
Yeah, no, that's great. For people who don't know what CGM is, that's continuous glucose monitoring. And they help us quite a bit with understanding the trends and habits that people have when they're going through their regular diet habits as it pertains to blood sugar, diabetes, prediabetes. I love how you said that. I love how you made that parallel. Now, how can we get people off some of these like acute sleep medications? What I'm seeing, and the name brands and all that stuff, people are on acute sleep medications and they're using it long term. People will come and they've been on them for years. There's no exit strategy. Yeah. Sometimes people don't even want to hear it, because it seems like a big leap. How do you work with that patient?
Yeah, no, it's doable. First of all, I always like to start off with giving hope. Like it's totally doable. But at the same time, like we have to try to figure out what was the driver of that problem in the first place.
Okay, so you got to go back.
So you have to go back. You going back to getting a good history of like what happened, what triggered this, and what do I think is the root cause of their insomnia. Is it like a behavioral problem? Is it a conditioned arousal? Is it a PTSD problem? Like what is the driver of that problem? And is it nutritional deficiency? Is it restless legs? Is it sleep apnea? Like what's the driver? And many times it's not just one thing, right? It's a multitude of things. And based on that, we can then have some kind of an idea or a timeline or a strategy of how we can wean this person off of this medication. And someone who's been on a sedative or a hypnotic for years, it's usually a many month journey, maybe 6 months, a year, of like slowly tapering them off so they don't have any rebound symptoms, they don't have any withdrawal. But if they've only been off of, on it for a few weeks, it's much easier to do that. And the way that we've been doing it, this is not in the guidelines, but this is the strategy that we have developed as an organization internally, is that we track the data from the medical grade sleep testing device over time while tapering the medications over time. And what that allows us to do is find out what is the lowest effective dose of a medication that this person would benefit from, and what is the sort of rate of tapering that we can think about as we come off of this medication. Because I've had patients where we're tapering one off of, I'll just sort of use a real example. A patient referred to us through one of our common colleagues who was on trazodone and Lunesta twice in a night. So he would take trazodone and Lunesta before going to bed, and then he would wake up in the middle of the night and take another trazodone and another Lunesta to be able to go back to sleep. So, and he had been on this for like maybe a decade, and over time the doses were going up. And what we had learned was, as we started to taper the medications, his sleep was kind of unchanged. He was more so taking this in fear that I won't be able to sleep if I don't take this. But when we looked at his sleep testing data across time, even as we were tapering the medications, his sleep architecture was kind of unchanged. So that gave me the confidence, and it gave him the confidence to easily come off of this medication. Sometimes we come off of these medications and their sleep becomes horrible, both symptomatically as well as objectively. And in those situations, maybe they're better off with a low dose of something. But at least we've gotten to the lowest effective dose, and people aren't like just blindly on, large doses of a sedative, hypnotic, Ambien, Lunesta, trazodone, mirtazapine. I mean, it can be a pretty long list of both FDA and non-FDA approved medications for this, but that's basically the idea. It depends on what's wrong, and doing it over time using data, it allows us to do that with a much higher level of confidence and precision.
So you're able to get all of that with the wearable ring.
Yeah, it's pretty powerful.
That's awesome. That's incredible. And as opposed to just doing a sleep study overnight where people have electrodes attached to their brain, this is over time. So you're getting more accurate data. You're looking at trends. You're looking at sleep patterns. You're looking at, different modifiables that make a huge difference that really, really curate a plan for a person, as opposed to just a one-night stand, so to speak, in a sleep lab with electrodes to your head. I don't understand that. I really don't, because it's just not natural. You're not going to get natural sleep. You're not going to get natural data when you have electrodes to your head and you're asked to sleep, watched for one night, as opposed to, going weeks to a couple months with a wearable where we can actually look at a person's, data in their natural habitat with their daily lives and draw out and extrapolate that trend. I think that's amazing. Yeah. I cannot wait to explore this with my patients, because I think this is going to make a huge difference, not just with people who have sleep apnea, but just sleep problems in general.
Totally.
I got to ask this question, because a lot of times when people encounter sleep problems, the first supplement they reach to is melatonin. What do you think about that?
Melatonin can work, but again, it depends on what's wrong, right? It's like if I have knee pain and the first thing I jump to is glucosamine, like that would not be the most intelligent way to approach it.
Okay.
You know what I mean? So like similarly, it depends on what's wrong. Where melatonin is extremely useful is in the setting of like when there is a circadian rhythm disruption,
okay,
either from jet lag or traveling across time zones or coming off of like night shifts to day shifts. So like, when our circadian rhythm is disrupted, in those situations, melatonin is extremely useful because it's retraining our circadian rhythm to entrain it to where we want it to be. But generally speaking, the way that I try to invite patients to think about this is like, why do you think you need melatonin? Like, tell me more about what's going on that makes you think that you need to take this. And if it's not helping for whatever reason, don't just keep increasing the doses over time, because our body makes melatonin.
Right.
Melatonin at the end of the day is a hormone.
Right.
So whenever we take something that is a hormone that is a part of some kind of a feedback mechanism, some feedback loop, whenever we take something exogenously, it's manipulating some endogenous feedback process.
Yeah.
So it's not wise to take it every day for unclear reasons. So sort of a long-winded way of saying, I think there's a utility for melatonin at the right dose, at the right time, in the right setting.
Yeah.
But using it like, hey, I don't sleep well, I'm going to take this for the whole 6 months. I don't necessarily agree with that approach.
So another way to put it is maybe you're saying that the best approach is when a person's circadian rhythms are off. If they're changing time zones, if they have jet lag, that's a good time to implement that to get back on track. But once you get back on track, put it away. It's almost kind of like considering vitamin C if you have a cold, kind of, right?
Yeah.
So what's good dose that people should try if they're in one of those situations?
Yeah, anywhere between 0.5 to 3 milligrams is enough melatonin to retrain the circadian rhythm.
Okay.
Like if we think about how much melatonin our body makes in a 24-hour period, it's like less than 1 milligram.
Mm-hmm.
And when you see people taking like these 5 milligram gummies or these 10 milligram gummies,
Right.
that's actually a very super therapeutic dose.
Yeah.
And anything less than 1 to 3 milligrams it should be sufficient. In fact, in the circadian literature, the dose that we recommend is 0.5 to 1 milligram.
Wow.
The problem is sort of with the over-the-counter melatonin that is falls into the category of supplements.
Mm-hmm.
The standard deviation in the dosing is actually quite wide. So like if we find a pill that says 1 milligram melatonin tablet, the standard deviation, meaning it could be up to 2 milligrams and it could be like less than like 0.5 milligrams. So it has a very wide standard deviation of what's actually in the pill.
Okay.
And melatonin is actually quite potent. So, anything under 1 to 3 milligrams should be sufficient.
Okay. So when a person picks up melatonin and says 1 or 3 milligrams, they're not necessarily getting 3 milligrams of melatonin. They're getting something that's, under that, but people don't need to do
Or
that.
more.
Mm-hmm. Or more? Right.
Yeah.
So, okay. Thank you. So people don't need to reach for that 5 or 10. They need to just stay somewhere around the 1 or 3
Mm-hmm.
or 0.5
exactly.
to the 3, like you said. I love that. I love that you said that. That's huge. That's going to help a lot of people. Now, let's talk about sleep hygiene for a second. What are your sleep hygiene nuggets? And then I'm going to get into asking you personally how you move, eat, drink, sleep. But I want to know, what are your sleep hygiene nuggets? What do you tell people that they can take away, and basic things that they can implement that every person should implement, whether they get great sleep or they're struggling?
I'll sort of start off with I like to start off with education. I think when we educate people, what we say makes a lot more sense, and it allows one to triage why one thing is more important than the other. And so if we look at sleep, sleep is regulated by two things. One is our circadian rhythm, and the second is how long we've been awake. So then one asks the question, like, what are things that I can do for my circadian rhythm? So for our circadian rhythm, waking up at the same time and going to bed at the same time, creating that circadian regularity, that circadian rhythmicity is critical.
Okay.
And that means like having darkness in the evening hours and having bright light in the morning hours. These are the two things that control our circadian rhythms. So going to bed at the same time, making sure that there's some darkness before we go to bed, waking up around the same time, and making sure that there's an ample amount of light upon awakening. That's healthy for our circadian rhythm. For sleeping, the two things that are probably the most leveraged and the most effective are reserving the bedroom for sleep.
That's
sleep
good.
or sex. We have heard of this many times before, like reserving the bedroom for sleep or sex, because what we don't want to do is create the association that the bedroom is a place of anything else.
That's good. That's good.
Okay.
Yeah.
We kind of like when we go to the kitchen, even if we're not hungry, we might pick at something because we've associated the kitchen as a place of food, eating, consumption, something along those lines. So similarly, if we associate our bedroom to a place of sleeping, then sleep onset happens faster.
Mm-hmm.
And the other thing to do from a sleep and bedroom standpoint is to equalize how much time we think we sleep to the time that we spend in bed. And what that means is if I think I'm a 7-hour sleeper, I shouldn't be spending 10 hours in bed.
That's
I
good.
might spend an extra 30 minutes in bed, because if I'm a 7-hour sleeper and I'm spending 10 hours in bed, I'm giving myself 3 hours of an opportunity to think about things that I should not be thinking about in bed. Those could be work, those could be family issues, those could be like anything. And so what I'm trying to do is eliminate the possibility of being in the bedroom awake thinking about non-sleep related things. That's one. And then the other thing is, from a circadian rhythm standpoint, having regularity and darkness at nighttime and bright light in the morning. Those are probably like the most, if one does that, their circadian rhythms will be pretty healthy, and the likelihood of developing insomnia is much lower. And if they do develop it, just doing something like this will substantially help them over time.
That is powerful. Powerful, what you just said. And these days we have TVs in our bedrooms. We watch movie in our bedrooms. And that's got to get in the way of what you just said.
Totally. And I think phones make they influence us. It's not, many times I catch myself using my phone, watching something, responding to emails, responding to texts before I go to bed. And luckily it's okay, because I'm a good sleeper. I'm generally a very good sleeper.
I would expect that.
But if you have someone
can't come
who's
on this
not
podcast, not be a good sleeper.
That would be a disgrace to the organization podcast if I was a bad sleeper.
Right.
But what the point is, if one is not the greatest of sleepers, and then we start incorporating habits that are not conducive to sleep, it'd be a very slippery slope downhill to develop even worse sleep.
Yeah.
And so just eliminating, I totally agree, eliminating the television, if one is going through a sleep crisis, trying to eliminate the phone out of the bedroom, charge it downstairs, doing these things actually make a pretty substantial difference. And they don't always happen overnight.
No.
Sleep is one of those, it's like nutrition, it's like diet. These things don't change overnight. It's a little bit of a process, and you do this for a week in a row, you see a little bit of results, and you may not think of you're making progress, but when you look at, how was my sleep a week ago or 2 weeks ago or 3 weeks ago, and you ask yourself that question, it's oh yeah, you know what, actually I am sleeping a little bit better. I am I'm not awake as much as I was a few weeks ago. I'm actually falling asleep much faster as compared to a few weeks ago. I'm waking up more rested as compared to a few weeks ago. It's a process. It's slow. It's not essentially these overnight things, these overnight magical things that happen. It just takes a little bit of time.
Yeah. I mean, charging your phone downstairs or out of your bedroom is brilliant, but it's probably punishment for some people. They're on punishment because they don't have their phone right next to them. But I think it's a great idea, and it's necessary. Some people, it might be hard to fathom, but it is definitely, it definitely goes along with great sleep hygiene. Now, what about the third shift worker? What do they do? I mean, because their circadian rhythms are just going to be the opposite. I mean, what do you tell people like that?
Yeah, it's hard. If someone is a shift worker, a nurse, working a graveyard shift at a gas station, working on an oil rig, the truck driver, the list goes on. There is no ideal solution, unfortunately. But what we can do is we can think about what can I do to accelerate my time to getting resynchronized to where I want to be. That's really the framework to think of it. I mean, I have patients that go from SFO to Beijing twice a month. I mean, and that's a very wide, time zone shift. And it usually takes about 1 day per hour time zone shifted. So if someone is shifting 14, 15 hours, you basically, like, they need 2 weeks to reacclimatize if there is no external intervention.
Yeah, that makes sense.
So the question becomes, how do I shorten that to just a few days versus it being a 2 week dragged out process?
Yeah.
And in these situations, there's no perfect situation. There's no perfect sort of solution here, but melatonin is extremely helpful. And modifying your dietary habits to get it to so that your circadian rhythms can entrain faster is again very helpful. So light and darkness are critical. Food timing is critical. And then the last thing is, if one is feeling tired during a night shift, is to use a stimulant medication, so that one doesn't make any mistakes, doesn't, it doesn't result in any injuries. And there's a whole bunch of different ones that can be used. These are FDA approved medications that can be used for what's called shift work disorder. And modafinil, Ritalin, methylphenidate-based medications. These can be extremely helpful to reduce the likelihood of having injury to yourself or to someone else. And they should be strongly considered. But there's really no good solution. Like, we're basically going against our evolutionary circadian rhythms, and it's just really hard.
Now, how do you move, eat, drink, sleep? That's my protocol that I put together to have and to help people have excellent health. At baseline, people need to move, eat, drink, sleep. And, I know also if people do that, they're going to also get good sleep, which is the S part. But because we know that chronic health problems can cause people to have poor sleep. We know that. Now, share with us personally, that acronym in your own life. How do you move? What do you do for exercise?
I go for a run, like 3 days a week or so. I go around the block. It's a 3.5 mile run. I try to do some push-ups or squats, like the days. So I have a pretty busy life. I have 3 kids, 8, 7, and 3. And before I jump in the shower, I'll just try to do, 15, 20, 30 push-ups. I try to do that whenever I have these little 5-minute chunks of breaks in between. So I'll try to do push-ups from an exercise standpoint, or go for a run a couple of days a week. And then from an eating standpoint, it becomes hard. The last sort of 4 or 5 months, I've gone back to time-restricted eating, where I try not to eat any calories before noon, and I try to stop eating after 7, so a 6 to 8 hour eating window. And then from a sleep standpoint, sometimes I'll end up doing a night shift for whatever reason, and if in those situations, I'll try to realign as quickly as possible using melatonin, the same things that we've discussed. But my sleep routine is kind of I generally like to go to bed early and wake up early, but sometimes with a family and a startup, that's hard to do.
Yeah.
And I will end up going to bed around 11 and waking up around sort of 6, 7 a.m. And get the kids ready for school and start the day.
And then when it comes to hydration, the D part, because you talked about move, talked about eating, the D part was hydration.
From a hydration standpoint, I probably overconsume caffeine, if I'm being honest to myself. I'll drink at least 4 cups a day, 2 to 4 cups a day, depending on the day. And I drink at least, 2 liters of water a day.
Yeah.
I have one of these bottles that are like marked.
Yeah.
And I'll just sort of go through that over the course of the day.
And the last part, sleep. You shared a little bit about that, but you said you get great sleep. So Please share.
Yeah, generally a really good sleeper. I typically don't have symptoms of insomnia unless if like something is burning down at the hospital or in the clinic. And I don't take any supplements. We have a very regular mattress. We don't have any blackout curtains. In fact, I sleep with the blinds open because I feel like it helps me wake up in the morning time.
Mm-hmm.
And nothing fancy. It's pretty simple. Like nothing. I've done multiple sleep studies on myself. If I have a few extra drinks of alcohol, I'll have sleep apnea. If I mild sleep apnea, if I don't drink and I'm not congested, my breathing is pretty healthy.
Wow. And this is great because you've used your wearable and you know what your sleep trend is. This is amazing. This has been an amazing show, amazing podcast. I cannot wait to have my audience, my patients, use the wearable to really get some powerful data on how they sleep so that we can optimize their sleep. This is big, and this is something your company, I think it's going to make a huge difference. And
yeah, no, thank you.
I'm excited to introduce your software to my audience and my patients. I think it's going to make a huge difference. And this is powerful. I'm going to have to try it myself. I'm pretty excited. And I'm going to have you back on because we can talk about this. We can talk about this for another hour. I mean, I have so many questions as far as sleep for recovery, sleep for athletes, so many things. And we'll dig into that another time. I'm just so glad that we had you on, Sahil. I'm so glad. Where can people find you?
Yeah, I mean, they can go to empowersleep.com, EMPOWER sleep.com, and they can learn more about Empower Sleep there. It's, these consumer grade wearable devices have created a lot of awareness and they're phenomenal tools, but these medical grade devices are even more formative, especially if someone has a sleep issue. If someone is a good sleeper and they don't have any suspected sleep issues, and using a medical grade device is probably more friction than it is comfort. But if someone has a sleep issue, instead of having to go to a lab to understand do they have sleep apnea or not, or all of the medical sort of disorders, then in these situations we can really create a lot of value and help them figure out what's going on and what's the root cause. And I'll send you a ring, Jason. I would love for you to try it. Always looking for feedback. Awesome. And we'll get you anybody else in your practice. We can get them set up.
I'll try it. Thank you. I'm looking forward to that. Yes, please do that. Send that right over. Thank you. I can't wait. I always say to people, in my move, eat, drink, sleep protocol that you want to make your bedroom like a spa. I think that's important because when you go to a spa, you go to relax. And I think that's important. You got to kick TV out, just like we talked about today. You got to move bills, newspapers out of your bedroom. You got to really make your bedroom like a spa. That's one of the baseline things you can do to get great sleep. Whatever you have to do. If you're not getting sleep, reduce your caffeine. Make sure that you, put your phone, recharge it downstairs. Do what you need to do so you can recharge your body, have optimum energy, and be in the best health that you can be. Okay, so you guys, until next time, thank you for listening to the Concierge Doc Podcast. I want to remind you, you can find us on Apple, Amazon, Spotify. Follow us on Facebook, Instagram, and LinkedIn as well. Thank you for listening. I appreciate you guys so much. Thank you so much.
Thank you, guys.